What's going to happen is that each speaker has 15 minutes, and then we'll have a discussion at the end, unless there's a few burning questions in between, and if there's time, we'll do that. We have our discussant with us, who's Professor Catherine Boydell as well. So without further ado, let's get going. We have a story to tell, or a few stories. This is about the ups and downs of resourcing, development and dissemination and sustaining of early intervention teams in Australia and the UK and Canada. Australia's research, clinical and affected community have been very successful until recently in nationally innovating and disseminating early intervention services for young people with psychosis and other psychiatric disorders. Youth-friendly headspace centres provide a one-stop shop approach to assessment of troubled young people and then connecting them with a range of mental health, substance use and physical health services. They are now widespread, and they have been the launching pad of a pilot program particularly in needy regions in each state and territory of specific formerly headspace managed young people with psychosis early intervention teams. And this is the definition of those teams. Oh, it's not working.
I'm sorry, I have to one moment close, I open again, 1 second.
Okay. It's broken. Okay. It'll come up, I guess, as... so the second slide, when you're ready, that gives you the definition of what those HIAP teams that we'll be referring to a fair bit are. These highly evidence-based teams, next slide, thanks, HIAP teams. These highly evidence-based teams were brought in on the basis of bipartisan political policy only a few years ago. They were now being told by our Federal Minister of Health that they face a stepwise dismantling by the Australian conservative federal government without giving them a proper chance to develop and bloom and to demonstrate the highly positive outcomes. This would lead to many sackings of committed and skilled team staff and a dashing of the much more hopeful expectations of many individuals and their families. And similar processes have been observed internationally, and particularly in the UK, in the wake of the shrinkage of the National Health Service on the watch of the current Conservative government. And we'll be coming back to that. How could we have prevented this disabled threat or dismantling? This is something we will deal with in this story. You've got there the definition of the HIAP teams, which I'll leave you to read, and you could ask Roger, our third speaker, more detail about that. And nearly up to the federal election in early 2016, our federal minister was intent on dismantling stepwise these teams which were in each territory and state, without giving them any chance to develop, stabilise and demonstrate the expected positive outcomes. The existing resources were to be sprinkled lightly over 31 primary health networks across the nation, which would redeploy them variably as the guidance provided by government is ambiguous and the primary health networks who are supposed to have the budget for them have little experience in this field and very different priorities to the youth focus and the prevention and intervention in psychosis. This would destroy fidelity to the evidence-based EIP model, which relies on a manageable geographic catchment area for 7-day home visiting, and also the expert staff who would lose their jobs or would be pressured to move on and would not be replaced. This is complicated. Hi, Eric. This is complicated also because this is the first time we had clinical teams in the non-government sector, because these were consortia that were often led by NGOs, and people had left their secure jobs in the public service to come to these teams because of their enthusiasm and commitment to working in this area. And then so they some of them had to scramble to think about, maybe I need to get back into the public sector. So there was some people who already started moving because of this destabilisation. The states could at best try to absorb the people that were supposed to be treated there back into superficial generic mental health services, which were incapable of providing the intensity and range of psychosocial function and clinical services needed. Such sprinkling provides no real challenge to the jurisdictions, as whatever they contractually promise in the jurisdictions, in reality, they were broke, and they would just absorb them into non-specific generic or gestural services which are devoid of evidence. It also represented a misunderstanding of the evidence. It was another example of us being victims of our own success in spreading the ripples of early intervention services to other conditions and age groups as a provisional paradigm shift whose time had come. David Shires and I published on this in the Early Intervention Journal in 2009. As it happens, well before this political decision had been made, our recent book edited by Peter Byrne and myself, and an invited chapter which was done by myself and Pat McGorry in the new textbook which has just been released by Alan Tasman called Psychiatry, which is a Wiley textbook. So I'll give you those details. The other way around. This is the book on all aspects of the evidence on early intervention in every age group and most disorders, which we published and launched in Britain last year. And this and the subsequent chapter, sorry, this is the issue about being the early talking about the early intervention of nearly everything was that we tried to include the kitchen sink, everything, a bit of everything. So you can find that in this frontispiece, that doodle that we put in. And that's the reference to the chapter of the book that's just come out. But we anticipated in some ways this argument and that you could do early intervention of all people through the same team. And this is the same thing that England is contending with at the moment now, and all conditions and to some extent all age groups. We needed to determine this question: what was the best balancing point in this dilemma between coherent age-specific teams for early intervention and more promising evidence for and widening access to early intervention as a timely approach for all mental health services to all conditions and all ages? And while we encouraged the development of early intervention approaches in all age groups and conditions, we also very squarely concluded that there is well-established and compelling evidence for retaining and further developing coherent, highly skilled teams for early intervention for young people with psychosis or at ultra-high risk of it. So they misunderstood our intentions, but when this crisis came up in Australia, we were able to give them and their advisors a lot of documentary evidence about why they should retain the early psychosis teams at the same time as encouraging the early intervention approach with all disorders and all age groups. The ensuing federal election networking and the consumer and family and media support and negotiations to retain these teams and their evidence-based functions intact will be described by our next speaker, Pat McGorry, including the ongoing steps taken to clarify and sustain the new government commitments. Now, I also want to mention, since Peter Byrne was supposed to be one of our speakers and he couldn't be here, there's a parallel UK experience. And there are some issues that have come up in the UK that you hear about a lot. But Peter, I'll just quote some of what Peter is saying. Having shown the most evidence of efficacy, the smartest economic modelling and sustaining flexibility of EIP services have mostly held on to their funding in a climate where England's mental health services have lost 8% of their budgets in real terms. There is a growing national awareness of mental health stigma and its need for parity of esteem with physical healthcare services. We would call that not just equality, but parity of services. And this has mostly led to a cross-party consensus that mental health initiative services like early intervention should be protected. But some early intervention services have not been immune from all budget cuts. An ideological drive towards competition for dominance of resources between services as opposed to competition to fight misery or deliver the best outcomes for people may pitch younger persons' services against early intervention teams that has already come to mean 18 to 36 services in the UK, which is beyond what has been mostly researched. And what I've done here is summarise some concerns that we've been hearing about the UK early intervention teams, which I may not have recorded accurately, so apologies if there are any errors up there, but these are the general themes that have come up. So I'll allow you to read that, and then I've got another one. So there are some of the more of the concerns that are coming up, but mainly about having to do more and more things with less and less for more and more age groups, losing the youth focus, losing touch with the evidence base, because the evidence base does not stretch to all age groups as yet, although there is some promising results in other age groups. And the main concern is that it may dilute and denature the culture and skills and expertise of a service which is vulnerable, which is vulnerable, young person friendly and developmentally focused. It may then lose its attractiveness to politicians because they get very concerned about young people as the general population does, but it becomes harder as people get older. So this is worth considering. There are some ameliorating things to say about those concerns, and that is, as Joe Smith pointed out the other day, all or most people with first episodes would be seen on a mobile basis in the community or at home, so teams do not necessarily need a youth-friendly base. Well, I question that because I wonder how many teams, I'm sure her team does that, but I'm wondering how many other teams in Britain are squarely all home delivery based and don't bring in people even to see the doctor. And you guys might be able to enlighten me about that, but having gone through a similar experience with assertive community treatment, one very prominent researcher in the UK told me, I don't think England does assertive. We are too polite. So that was trying to show results of assertive teams compared to some of our Australian teams. So the other ameliorating factor may be that early intervention teams may be able to take on a very small percentage of severe forms of other diagnostic groups and apply similar sets of interventions without being swamped or without dismantling the early intervention evidence-based framework that you have for young people. This would be for other young people with the most severe end of other disorders, and you'd have the same structure, but you'd only do that for a very small percentage of people, because otherwise you would, again, disrupt the structures you'd set up for others. So, just to conclude, the onus, this is what Peter Burns says, the onus is on all of us to keep helping our most vulnerable service users and our family carers, proving the best outcomes and advocating for early intervention services, and particularly for young people, but perhaps at least located separately for younger people and for other age groups and other conditions where the evidence is beginning to be promising, which also require distinct resource enhancements to be effective. So I'll leave it there. And I'd just like to say that when we're talking about recovery, we should be talking about a recovering person, a recovering family, but certainly recovering mental health professionals. And I think all of us in this room probably can number ourselves amongst that, I hope. Okay, so now I will hand over Professor Pat McGorry, who has been introduced so many times in this conference. I don't think he needs any further introduction, so just hand over to Pat.
Okay. Well, I can definitely say I'm a recovering psychiatrist after what I'm about to talk about. So as Alan said, this is a great idea of Alan's to kind of have a symposium here, and it's great that Roger's here too.
We planned it while the crisis was still on.
Yeah. So it's a happy ending so far, although you can never trust anyone. Yeah. So I thought some of you might have heard me talk a little bit about this in another symposium when we were talking about different countries' evolution of services. But so I just thought I'd start at the beginning, and this is where we started in Australia, at least, with first episode psychosis in 1984. This is a very unpromising looking building, isn't it? But and it was named after Aubrey Lewis, who was a very unpromising psychiatrist for early intervention. So nevertheless, and we've kind of evolved over the years, and as Alan kind of very nicely described it all, it's been an evolution, and the first, so that was the first model program that we had, which was very much modelled on what they had been doing in New South Wales, Roger and Alan, with the community psychiatry revolutions there, with assertive community treatment, home-based treatment. We built those elements into the first episode and had early detection teams as well, I suppose, as part of it, and a guaranteed tenure of care, which critics would say, well, why are you discharging them after 2 years? It's too short. But actually the median length of care in public mental health in Australia is about 6 months or maybe 12 months if you're lucky. So it was longer. They were getting a guaranteed, even if they were better, they were being retained and looked after to keep well. So there's a very big difference. And we had quite a momentum at first. We had several national conferences on early intervention, and Alan set up teams in Sydney, and state governments started to put a little bit of money into these things. But it was really, it wasn't a fully fledged sort of, it was very hard to get them to invest properly in it. And I think the thing that made it possible was what they had done with these community mental health reforms. So that the kind of centre of gravity of care was shifting to the community, it seemed, in the context of deinstitutionalisation, and that was the promise which they kind of reneged on as governments as time went on. But that laid the groundwork for these early intervention teams to be established. And in the UK, that happened a bit later, but they scaled it up in a much more effective way across the country, both community treatment and early intervention at the same time in the Blair government. But for some inexplicable reason, and I still don't understand this, they positioned the early intervention services behind the community mental health teams. And it took them 20 years to work out that they still had a long DUP, and they couldn't work out why. Well, it's pretty obvious why, because you had to refer via a big quicksand thing in the middle, which lengthened the DUP. Anyway, that's just a bit of an aside. But so these reforms, happened in a context which made them possible, I suppose. And that's what I'm trying to say. And the community mental health idea that Alan and Roger pioneered in Australia was very important for us. I just want to acknowledge that. So that was happening in the 90s, and we had some investment from the federal government in something called the National Early Psychosis Project, which put seed workers in each capital city and started to promote the idea, and we produced some clinical practice guidelines. But then it kind of stalled, pretty much, and we couldn't get state or federal governments to really grow the system. And really the only fully fledged early psychosis program until the more recent investment, which happened in 2011, sort of nearly 20 years later, so it was really stuck. And as I said yesterday, it took the youth mental health big picture, sort of high volume investments to really revive the possibility of getting money for early psychosis. And I remember that in 2008 we had the IPA meeting in Melbourne, and the day before we got someone from who was very influential on the National Health and Hospitals Reform Commission at that point, Rob Knowles, an advocate. He had been a former Victorian Health Minister. And Bill Shorten, who's currently the leader of the opposition Labor Party in Australia, to launch sort of a statewide, a nationwide forum on early psychosis as a prelude to the IEPA meeting, and that kind of got it back on the agenda a bit. And then we did this nationally commissioned early psychosis feasibility study report, which Owen Kalaki prepared, and this was in the lead up to the 2011 budget, which announced a big expansion of headspace centres and also for the first time Commonwealth investment in these more specialised early psychosis services, which had previously been seen as a state responsibility, a state government responsibility. So they said they were going to fund 16 of these services, and actually there were 16 core components of the model as we defined it, and so the services would have to have fidelity to these components, and the cost structure of what was funded per service was built up on the basis of the available evidence, for things like family workers, IPS workers, and a certain number of case managers according to case loads, and it was all carefully designed and costed, and it was pretty well funded, and there were things that we had never been able to fund before, like, for example, the employment workers and so on. And it was having 16 of these services was based on the notion that the state governments would co-invest under what was called a National Partnership Agreement model of care. So the Commonwealth put money in and the states has to put money in too, and the states get to run the thing. The trouble was the states didn't play fair. Most of them refused to co-invest, and they wanted to take the Commonwealth money, federal government money, and spread it out across the whole state as though there was nothing ever going to happen again. Whereas the money had been designed and configured on the basis of discrete services in certain locations, which certainly wasn't statewide coverage. There wasn't enough money in that first investment to cover a whole state. But the state governments, in a kind of greedy and short-sighted way, just wanted to, take the money and give everybody 50 cents. And so, luckily, we had a good federal health minister at that point. Probably the best one I ever met in politics ever, a guy called Mark Butler, who was the mental health minister, and he was senior enough in the government to actually be in the cabinet, which was a big thing for mental health, and he was very smart. And they funded us at Origin to provide support for this reform. So what Mark Butler did was say, right, state governments, we're not going to give you the money after all under the NPA. We're going to fund it ourselves directly, and we're going to give it to Headspace to commission and allocate alongside Headspace centres. So rather than it being sort of located in the tertiary system and administered through there, it was being run through primary care structures and NGO-led in many cases, as Alan alluded to. So. And that was a challenge because the more specialised workers hadn't really ever worked in those settings. They tended to work in hospitals, and so imagine getting psychiatrists to go and work in an NGO, for example. That was a bit of a leap of faith, for these people. And for these reasons and a whole lot of other, sort of political reasons, it took a fair while to get this money flowing, and that weakened the situation a bit. It allowed criticisms and anxieties to build a bit, but so in 2013 we had another election, and this time the Conservative government got back in. And they decided to hold, or they asked the National Mental Health Commission, which had been set up by the Labor government, to review all mental health expenditures by the Commonwealth. And everything kind of got paralysed in mental health for 2 or 3 years because of that. And their recommendations were actually to support the continuation of early psychosis services and Headspace, which were evidence-based programs, as Alan said. But they were going to devolve the commissioning. There was one of the possible recommendations to devolve the commissioning to what became primary health networks. 31 of these networks across Australia, sort of sitting in between the federal government and the state governments in a way, in a regional sort of commissioning framework. And that was fun. That was probably fine. It wasn't ideal, I think, but in some ways. But it would have been fine if the fidelity and the ring fencing of these programs had been protected. But as Alan said, in November 2015, they announced they were going to just allow these primary health networks to just use the early psychosis money. So the early psychosis services, which had by now taken shape in most places, but were still fairly embryonic in many ways. They hadn't really hit their straps. They were to be dismantled over 2 or 3 years, and the money flow into the primary health networks to do whatever they felt like doing in mental health, pretty much. And it wasn't even safe that they would keep the money in mental health. So disaster, from that point of view. And Headspace, they pretended that Headspace was okay for 2 years, but that they had the same intent that after 2 years they would give freedom for the primary health networks to kind of spend that money on youth mental health in some other ways if they wanted. So, and that was the big card that we were able to play then. That was a very important card when it came to retrieving the situation. But anyway, I'm just showing you a few slides to show you the amount of effort that had gone into building this, this new system. And we had funding from the federal government at Origin to actually help with service development, to work with these new agencies in a supportive way, along with Headspace, who also had a role with this. This is what Alan was referring to. And there was, just go back. So there's also a workforce training thing. I think I've got some slides on that too, but I'll just mention that too. There are two foci. One was creating and developing the service, and the second was looking after and skilling up the workforce. But then in November 2015, there was this this problem. So the design of the model had to be adapted a bit because it was being embedded in a primary care environment. So the access to more specialised care should be much more seamless coming out of Headspace intakes. But the elements were meant to still be there, and mobile home treatment and all these things were built in. So these were the sites. How many have we got there? 1, 2, 3, 4, 5, 6, 7, 8. So we had 8 originally. It's shrunk now to 6 because Tasmania was kind of excised from the Australian sort of nation at this point, and so was the capital, Canberra. So they missed out on their services, and they were compensated a bit further down the track. And these are the levels of activity that we provided to these services from Origin. So many visits and training exercises and so on. Okay, so these are some of the training frameworks, including online, using a learning management system, webinars and that sort of stuff, based on a community of practice sort of idea. 19 manuals were written, based, just condensing all the evidence that we had internationally for practice in the different aspects of care, and sort of simpler, clinical practice point documents. So a lot of effort was I've certainly never seen anything like that occur in Australia to that level of kind of support and I suppose resources for a reform like this. And we even set up an early psychosis research network to capitalise on the research opportunities that would come from such a system. Now, back to the election. So this announcement was made in November 2015 that we were looking down the barrel in both of these major reforms, which we had spent either I suppose 25 plus years in the case of early psychosis, but about 10 years in the case of Headspace, just scaling them up and actually creating these beachheads. And so we had to really think how we were going to stop this. And fortunately, this man, the new Prime Minister who replaced a Prime Minister called Tony Abbott earlier in the year, he had become the Prime Minister just before this announcement was made about the cuts. But here he is in the election campaign some months later, in June, opening a Headspace in his own electorate. Now, completely oblivious, I think, to the evil scenario that was unfolding under his health minister and the health department. And by the way, the health minister, we have to blame her to some degree, but it was really the Department of Health that came up with this plan of dismantling the services, and it was a couple of senior bureaucrats in the Department of Health who are really to blame here. And The health minister just acted on their advice in a sense, and she didn't really, I don't think she really understood the implications politically, because Headspace in particular is incredibly popular amongst local MPs around the country because it's actually something that's visible in their electorate that they've had a role in establishing. It's popular with the community. The community has got a lot of buy-in. They probably wouldn't die in the ditch for early psychosis services, but they definitely would die in the ditch for the Headspace model. So we decided to we spent a lot of time talking to Alan and Roger and other people in the early psychosis services around Australia, trying to get people to work together and fight it. Because there's a kind of learned helplessness in mental health. You've just got to suck it up. If they cut your services, well, that's bad luck, you know. You never would see that in cancer or hip surgery, for example. If someone touches an orthopaedic surgeon's world, that you better be ready for pain, because you know they're not going to take it lying down. So that's the attitude we've got to cultivate in mental health too. So what we did over those 6 months prior to the election was try everything behind the scenes. You know, we had a lot of support amongst these conservative government front benches and back benches, and on all sides of politics actually. So we told everyone what's happening and, you know, trying to get them to intervene and help, and they didn't really do anything, you know, even though if something did change, they would have been happy, but they didn't actually feel they could step on the toes of this health minister. They're worried about sticking to their portfolio and all of that. Prime Minister, we did try to explain to him what was going on, and reasonably good access, but I don't think he really understood totally, as evidenced by this, because he thought everything was okay. And they refused to really believe that Headspace was vulnerable. They tried to say, well, no, we don't mean Headspace, we just mean early psychosis, but it was pretty clear. So then, this is in the election campaign. I was lucky enough, you know, to get an opportunity to speak at the National Press Club. I asked them if I could, and I didn't expect them to say yes, but they had a bit of a slot because the government decided not to make health an issue in the election campaign. They didn't want to put more money into the health system generally, so they wanted a small target, and they didn't trust their health minister. I hope this room is not bugged, but they didn't. I don't think they trusted the health minister to actually speak publicly on health, and the Labor Party was campaigning really hard on health and how the Conservatives were going to dismantle Medicare, and so they didn't want to have that as a debating issue. So there was nothing at the National Press Club in the election campaign on health. So when I said I want to talk about mental health, they said, oh, well, we've got nothing on health, we really want to have something on health. So they gave me the Guernsey and I got to talk about it. And I got a young person to come with me. Nicole was her name, Nicole Juniper, and she gave a fantastic talk about the benefit of this type of care, and you know, and I just explained exactly what had been happening and what the outcomes would be, and they were concerned about suicide rates, which were rising as well, and we linked up those arguments too. So now I wasn't sure if that was going to do anything, but talking to Roger and Karen Burns, who manages the service that Roger works in, the Sunday Telegraph had been doing in Sydney, the major newspaper on Sundays in Sydney, had been doing stories on youth mental health, just sort of, I suppose, positive stories in a way for several weeks. And fortunately, you know, some of the editorial people had kids being treated in these services, as I understand it. Roger might be able to expand on that, the backstory there, but this newspaper then suddenly got very much engaged, and they had seen this talk as well, and so it was explained exactly what was happening. In fact, the Prime Minister's advisor sat through the talk too, and you know, so that was also good. You know. And so this is what happened next. You know, on a Sunday morning, what was the date? Something like 2 weeks out from the election.
It was exactly 2 weeks before.
2 weeks before the election.
Sunday before the election.
Yeah.
13 days.
So the Prime Minister's name is Malcolm, I nearly said Fraser, but Malcolm Turnbull. And so, hey Mal, we need to talk. PM's health plan puts youth suicide help at risk. And there's a whole expose, you know, in the next few pages about this. And by the time this happened, well, the next thing that happened was that they got in touch with us very quickly and said, how do we fix this? You know, because the election was on a knife edge. You know, if the election had been safe for them, they probably wouldn't have done anything. but they were very worried about losing the election, and so they kind of got onto it straight away. And by, I would say, 11:30 that morning, it was all negotiated that it was all going to be completely fixed. All the money was going to be put back in, and there were going to be another 10 headspaces. And I think there were a couple of other things. I just forget the details, but they were just falling over themselves. We probably could have asked them for another $500 million if we really played our cards right.
The money they were taking out and were going to sprinkle got left sprinkled.
Yeah,
well. So
that was the win.
There's a $40 million extra money for mental health as a result of this.
That's right. Roger's right, because they put the money back in, but they'd already promised to put some compensation money into different things called Youth Severe, whatever that was, and no evidence base for that, but they just thought they'd do that. Anyway, it was a very instructive thing, and it sounds like we're showing off a bit here, but actually it's very, very instructive for the mental health field. I don't know if people in Australia have seen this lesson yet, but if you just try to operate on the inside all the time and appease these people, you're just not going to. It's not going to work. You obviously try to do both. You work on the inside as best you can, but if it's going pear-shaped, you really have to step outside. And they're weak. They're weak, and they will give in, especially if the conditions are right. And the media will help us. And that's another big lesson. The media will help us because the media have got kids. The media know about this issue. They haven't all got psychotic kids, but most of them have got depressed kids, or there's some problem in their family. So if you go broader, you will get that public support in the media. And the politicians, the other thing I learned through all this is that the politicians think the media is the public, and especially this media, because this is the biggest selling newspaper in New South Wales on a Sunday, and Canberra. Yeah, but I think in this case, the marginal seat that Roger's service is sitting in, which
it covers lower socioeconomic groups. It's one of the Murdoch papers.
Yeah.
And it was all the areas where they had swing electorates were covered.
Yeah. I'm probably stealing too much of Roger's thunder because he's probably going to talk about that in a minute, but he'll have a different perspective on it anyway. So this happened then, probably about a week later, when they enshrined all of these agreements. And I had emails. The minister tapped out an email in my presence about all the things that she had agreed to and sent it. So we had it anyway. But it found its way word for word into their election commitment. So and now, and this is the other lesson that I think I learned, and hopefully other people will be able to see too, and at least in Australia. I don't know if it works the same in other countries, but if you actually challenge them and they come to an agreement with you, they will not actually punish you afterwards, even though you force them into it. They're their new best friends. So there's no friends in politics. It's about the negotiation and about the outcome. So I think we make the mistake, mental health advocates, quite often, that we have to curry favour, we have to get them on side and all this kind of stuff. Well, yes and no. I mean, it's good if you can. And like with Mark Butler, that was definitely the way to operate with him, because he was well-intentioned and he was smart and he had money. There's no point in fighting with someone like that. But if the people have got are doing the wrong thing, then this is the way to go, I think. And you might lose sometimes, and we were lucky probably because it was a tight election and it could have not worked. But the other thing I want to say, because Chi's sitting there in the front row, is that we got great support from the international brotherhood and sisterhood of early intervention, and we got letters from Epion in Ontario and from a number of other people too. So that was really good. That was a really good thing. And as Alan said, this is part of a wider phenomenon. These services are constantly at risk, and even when you think you've got it over the line with an evidence base and investment, and there are always ways in mental health that they can cut. And the rest of the health budget is just going up like this in every country all the time. It never goes backwards, but in mental health it can go backwards. So this is about the parity issue and not just parity of esteem, but equity, I think, isn't it? So as a possible antidote to that, this is the last slide, we're trying to set up this thing in Australia, which is much more of a grassroots movement. And in the 2010 election, when we did begin to get a lot of traction in mental health, there's an organisation called Get Up, which is a grassroots campaigning, through electronic, media and so on, especially, but very political, and takes up issues and fights for them. To get them on the agenda. So it's large numbers of people, and in that election there was 100,000 signatures for something to be done about mental health, and so you're mobilising masses of people. And so they said they couldn't keep campaigning on mental health for us, but they advised us to set up a similar thing for just for mental health. And it took us a few years to get that done, and it has started now, but it's still extremely embryonic, and it needs money. You probably need about $500,000 a year to finance something like this at least, and then it can crowdfund and support itself. But that's what we're trying to do, and you can see that the logo is very instructive. It is about people power, and it's about not taking this kind of discrimination that we actually experience in mental health anymore. Why should people put up with it? And it's sort of, we were very, very angry about what actually happened, but we had to remain calm and come up with a strategy that was actually going to work. And it's organising the services, organising all the forces that we possibly could. And the other thing to say is that having had that reversed, the people in the government who are our supporters, they completely understand why we had to do that. So I don't think there's any ill feeling there, except possibly the health minister. But she's struggling in other ways. So I think she can't afford for it to go pear-shaped now. It's got. Now, Alan and I have been talking about this, and Roger, how the money gets released, because they're very slow to release it. I don't think there's any intention, because of the politics, not to do it, because they wouldn't get away with not doing it. But making the money flow and repairing the holes that they created is the issue now. It's a more practical issue, which the services, the 6 centres are working together to kind of, and communicating really well to try and address that. And we had a meeting with the Health Minister about a week or so ago, John Moran and I, and we managed to get her to commit to releasing that money, prior to the mid-year financial statement, which would have been a potential barrier. So I think it will flow fairly soon, and the Health Department has changed its tune and its messaging to some degree, hasn't it? Okay, so I'll probably talk too long. Sorry if I overlap with you, Roger. So I'll stop there.
Thank you, Pat. I must say that when we started having network meetings of all the HIAPs, there were some people who thought we really couldn't do much about this, but I think there were a couple of key things that we talked about at those network meetings initially, and that was, why are we being therapeutically pessimistic about what we can do? Why, if we operationalise therapeutic optimism for our clients, why don't we do it in ourselves? And the other key issue was when Pat said, I think this is winnable, and then mapped out how we could do it. And I think it flowed from there. I think the strength in finding that people do respect you if you are strong, and then resetting the issues from there, then you start getting letters back from the minister in your first name when.
Okay. Yes. Well.
Oh, sorry.
I don't have to introduce me. Yes. Alan and I have been campaigners for at least 40 years in trying to achieve change in mental health services. And I think most of the people here in the room have come to this late session on the last afternoon. You must be campaigners as well. And I think I'm someone who wants to actually get there and try and implement things, which means I haven't had time to be an academic as well, particularly. But you learn a lot of things on the way from the different perspectives, and I just think this has been an excellent example of national teamwork where different people had different roles and responsibilities in the process. And because I'm employed by an NGO, I have to look after the interests of my chief executive rather than being out front. So I'm one of the people who really has to stay behind the scene, but there's no doubt that we all had a very definite role to play. Now, I've got some slides here, but I'm going to romp through some of them and ditch some of them because I think I've got too much material. And the thing about Australia is there are so many individualistic sort of things about our country that I'm sure each country really has a lot of detail about the methodology you need to use to achieve change. So, I mean, we've had a long history of trying to bring about change. We have national mental health plans, except for the first one, though. They've managed to evolve into something that has no clear goals and no measurable outcomes. After the first one, which did have some of those things, the senior public servants realised their error and made sure that no minister would be embarrassed in the future. We've just had our fifth plan released this week. I haven't seen the content yet, but I doubt that it's going to show much there either. And, you know, we all know, and this is another example of how hard and slow it is to actually get the evidence base actually implemented. So we spent about, it's been lately calculated $28.6 billion or 2.2% of GDP on mental health services, but we still get really poor outcomes due to fragmentation and the diverse funding and expenditure arrangements. So, and I'm someone who's really keen on funding methodologies because I actually really believe you get exactly what you pay for. And it's who pays it and how they pay it is tremendously important in terms of the outcomes. And so we've often, though, had the implementation of evidence by name only. I think we've seen this in the UK and other places. They'll put the trendy title on the name of the team, but there's no actual fidelity to anything based on evidence inside the team and what they actually do. And there's also a system psychology issue that gets missed out. As being a manager of services, I looked after 1.2 million people in Western Sydney as an area director. Sorry. And the problem is that people, even though they get the name and they may get some fidelity material that they need to adhere to, there's not that understanding of how do you actually lead clinicians to change their behaviour within a team to ensure that all the different components of a team actually work together in an integrated way. So there's been lots of that. Now, I'm going to skip over some of these things. Just Australia, people think Australia has a health system. Well, I'm sorry, it doesn't. It's actually a cobbled together lot of historical factors. And really, if we get to it, we have amazing problems in terms of how the funding goes. So, for example, in mental health, we have this organisation called Medicare, which is where the federal government subsidises private practitioners. And that's been going up about 6% per year for mental health in the last 5 years of data. But guess where the money goes? Well, a freedom of information process showed that the Medicare money goes to the wealthiest parts, and the electorate that gets the most money is Turnbull, the Prime Minister's electorate. And one of the electorates in New South Wales that got the least is where I work out in Western Sydney, an area with lots of public housing. The same happens with the state's employed staff, that they're highly variable in terms of their distribution. So the eastern suburbs of Sydney had 5 times as many community-based staff as the city of Blacktown in the western of Sydney. So anyway, so that's just some detail. But the real problem in Australia is our federation, and trying to get that reformed is a major issue in terms of getting sense in any part of health, including mental health. Our Commonwealth Government now raises 82% of taxes, and the states only 18%, but the states under the Constitution are supposed to be the service providers, and they need 40% of the public dollar to do that. So they don't have the money, they're always at the mercy of the federal government, and they're always broke, basically. Then you've got a real problem about distribution of responsibility. So basically, the Commonwealth said, OK, well, it's going to look after primary care. So it does activities around general practice and primary care, including allied health. Then the states are left with the hospitals, the expensive part of the system, the tertiary parts of the system. But between there, you have these secondary level services, and that's a vacuum. Neither level of government wants to be really responsible for the effectiveness of the secondary level care. And of course, the HEP program is absolutely a secondary level care because it's specialist, it's not tertiary and hospital, and it just sits there, which is why it's actually very vulnerable, because that's what influenced our federal government and our health minister and the senior public servants. They are saying, I'm sure, why is the Commonwealth actually funding this secondary service when it really should be the state doing it? But the state doesn't have the money to do it, and it has these little early intervention teams, like 4 people and half a psychiatrist scattered around, but they really cannot apply any model that's actually effective. So that's why I jumped ship. I was actually working in the state system. I was looking after a Blacktown Early Access team, which I set up in the 90s to deal with the 12 to 25-year-olds, because nobody else would. And I was only allowed to go there. There was only funding, in a way, for me to go there for 3 afternoons a week to deal with. I had 120 clients on my books, and that was such a small proportion of the people in that city of 350,000 people that needed the service. So I could theoretically only see my young people maybe twice in 6 months if I was lucky. So we really got failed state systems, and so jumping ship for me was to say, well, I need to make sure that the HEP program actually works. I need to make sure it's a success in Western Sydney, because otherwise there are plenty of enemies who would write it off and say, well, we've been there, we've done that, doesn't work, we'll do something else. Okay, and one of the things that, there's lots of cost shifting, but the other thing is that the people who work in the state system are very dissatisfied. So 38% of the psychiatrists in the New South Wales system, in a survey about a year ago, 38% said we want to leave the system because of the poor activity. Okay, I'm not going to deal with that. These primary health networks that were mentioned are actually matched to fit along with the borders for local health districts. So the local health districts run the hospitals under the state-funded system. The primary health networks are Commonwealth-funded, and they're supposed to do population health management between them. But of course, that requires the PHNs to have a lot more knowledge about services that are required than they actually have, and they're still biased towards doing what a GP thinks they'd like to have happen. And the Commonwealth has sent out 8 different documents to the PHNs around mental health, giving them guidance about how they should invest their money. However, of course, it's the old thing that we were talking about with Ian and so on, that it's about stepped care is what they're saying. Everything should be stepped care rather than actually being able to say, no, we write that, immediately you can see some people who, in terms of the staging process, need a specialist service right now. And of course, those specialist services don't exist. Okay, and oops, where's this going? What I really want to talk about, though, is I think people need to step back and actually understand the political process. Now, just to finish off the story earlier, Pat was doing his thing that he can do because he was made Australia of the Year in 2010, and he was able to actually have those high-level contacts. Alan was able to pester the minister no end by being the one who just got in there and worked at it. And my role turned out to be, well, I've got other contacts. So I happen to be the chairman of the board of a torture and trauma service, and I have a lobbyist who sits on that board. So I asked my mate, that lobbyist, to say, can you help me with this? How can we actually get into the media about this? And he had a mate who happened to have a son who happens to have bipolar disorder, who his partner happened to be the deputy editor of the Sunday Telegraph. So that's how we actually, the 3 degrees of separation meant we actually got to someone who was actually altruistic and interested in doing something about it. But again, I had to make sure that my chief executive got on side. So my job was to actually make sure she directly talked to Pat and talked to Alan, because you are the one who actually strengthened her backbone to actually say, yes, she'll take the risk of having a go and maybe winnable. Because she was all for saying, oh, I have to deal with this PHN and, we'll lose these other contracts, or there's so much at stake, worry. But it really, the politicians always say to you after you've taken action, oh, did you have to go to the media? And of course, well, if you don't go to the media, you don't get nothing. So it's, again, as Pat says, they do forgive you afterwards. Once they've realised they've done something that actually is then praised, and the Sunday Telegraph the week after, being a Murdoch paper and actually wanting to see a Conservative government elected, put an article in that say what a wonderful thing Turnbull had done in terms of improving the mental health of the nation. So, you know, those are the things that happen. But if you're going to try and change something, you really have to actually think about it in terms of, you know, what's the timing? How do things change? So you have to think about it in terms of the problem stream, in terms of, well, what are the problems that need to be dealt with? What's the policy stream in terms of what's happening around with policy and how we can connect those things? And then also what's happening politically? How can you link it to the mood of the community and the politics of the time? So effective lobbying and advocacy means managing those things. So you need to identify and prepare a clear and simple communication strategy for articulating a policy or practice problem. You need to develop and communicate a positive response to the problem that's attractive to key stakeholders, and articulate a clear, tight and positively framed argument which hits the mark on both emotional appeal and economic rationalist arguments. And you need to, as I say, attach that and think about the other things that are happening. So at the moment, for example, in Australia, activity-based funding is all the rage, and that's what's happening into general health. And for mental health, Alan and I made sure, though, we got onto the mental health working group for that within mental health, because if you don't get in there and try and influence it, these things could affect the HEP program, these could affect all these other things down the track, and they're so poor at dealing with the community part of things. We had some wins in terms of getting a phase of care process for that, but these things cost history, and they actually look at the pricing of what people are doing now, not what they should be doing. And so there's a real danger that, you know, they'll come up with pricing that's totally inadequate for what's needed. But, okay, so then you've got to wait for or manufacture a window of opportunity. You know, you've got to deal with claims of crisis or chronic underfunding need to be spiced up with more positively framed arguments, and those are things that Pat does very well. And it's not enough to complain about the problem. We also need to really come up with attractive solutions. You know, managers don't need problems, managers need solutions, and that includes politicians. Politicians are amateurs, they hire advisors. The advisors they hire are people who have knowledge about the politics of the sector, not about the evidence base. So even relying on a minister's advisors often doesn't work very well. And the senior public servants in Australia rotate every 2 years, are expected to. So they're all amateurs, they have no knowledge about the content of whatever policy they come up with. And so the Westminster system has a lot to answer for in terms of things. So that's why Alan and I and others worked very hard to try and bring about change in terms of mental health literacy, and to also enable governments to have some advice outside of the Westminster system public service process, which is why we really pushed for mental health commissions, because they can be knowledge management organisations at some arm's length from government. They can talk to all the stakeholders and come up with some ideas that then government may or may not actually apply, but there's a little bit of wriggle room still for government, but on the other hand is more effective. So there's a bit of history of things there here, though, where we've actually had, in a sense, some successes. In New Zealand, they had a mental health commission that produced a blueprint which really set down exactly what you should be applying based on the evidence base of the time and in terms of the resources you need, etc. And when they managed to get that onto the platform of an incoming Labor government, they then actually implemented it. So New Zealand shot ahead in terms of being the country near us that had the best outcomes. We worked on mental health commissions through those different years. I mean, getting an incoming Labor government, you know, again, gave Patrick the Australian of the Year, and that was tremendously useful, again, in raising the profile of mental health and its needs. And other things came along, like that. There was a Labor again came up with a national disability insurance scheme, which was going to be really based on people with developmental disability and so on, but we were able to jump in and make sure they included mental health in that. So incoming themes are incoming governments. If you've got likely to have a change of government, that's the time to really talk to the opposition about what they could do in government. The other thing is with Mark Butler, you've got young politicians who want to make their mark. They actually want to, you know, have something to put up as being something they achieved. So go look for those politicians as well in the process. Okay, there's a lot of other things. Never give up, I think is the answer. Because we've had 40 years of working through all the different ways you can actually try and implement it. You know, you never let an inquiry go past without having a submission. You always have something on the shelf that you may be able to pick up with. And I tried to go through management and bring about change as a manager and discovered how difficult that is, trying to change institutions as a middle manager effectively. Alan became a mental health commissioner, and that, as long as you could stand it, yeah. So, okay. There are a range of things that actually make it easier. And we at our mental health services conference, we actually had a guy, Dr. Evans from Philadelphia, is even in the USA, if someone gets all the funding from the federal government, the state government, the county or the city or the whatever, and they've got it in their hand, he could actually really make change for the 1.5 million people within the city of Philadelphia. We dream of having similar things in Australia where mental health or health ends up on one layer of government so that you can actually make sure that things work together. Thank you.
Roger has been a beacon to us in being prepared to run services at every level of the hierarchy, from the middle to the top. And then also he's been the treasurer of every worthwhile organisation, including Amnesty International in Australia and the Mental Health Service Conference of Australia and New Zealand. I have pleasure in now asking Chai Cheng to come up, Professor Chai Cheng, who is from Northern Ontario but is centrally involved in running the Epion network, who Pat mentioned as being a great support to us in our time of strife, but also we need a good practice example of how you actually do stability and continuous development of services and what sort of factors you need in there, and Chai will tell us about that. So thank you, Chai, and thank you for doing this.
Thanks to Alan for inviting me. I feel a little bit like an interloper since I'm from Canada. Alan said, you're supposed to be the beacon of hope for stability and funding. I thought, oh boy, okay. So I scattered throughout my slides are pictures of Ontario, from where I am from, hoping to invite you to visit and move to Ontario if really things get bad where you are. And this is this is right in front of my house. This is the view from my front door. Yeah, just a bit show off there. Yeah. Okay. So for those of you who don't know, Canada is here. You can't really see the outline of Canada, but Ontario is the East Middle Province. I'm just giving you an example. I service this area here, which is Northwest Ontario, size of France. My European colleagues always are very impressed when I tell them that I service that entire area, and there's one EPI service in that entire, or EPI program in that entire area. And I went up to Thunder Bay, which is here, about 10 years ago to help them start their very first and only EPI program. Here's Toronto, and out west here is Vancouver, for those of you who can see this, and then Montreal's here, just so you have some geographic landing. But I'm here as Epion chair. So Epion is the Early Psychosis Intervention Ontario Network. We were lucky enough about 12 years ago where the Ontario government decided that they were going to fund EPI programs to cover every square kilometre in Ontario. And so this is a map of Ontario where all of our programs, we now are 56. And so there's only one here, but we're supposed to service all of there. So it's just to give you a sense, every square kilometre. So if you live in, Moosonee, which is up here, you're supposed to be able to receive EPI services. If you're down here, you have a whole bunch of places that you can access. And so this is just to give you an idea of our network. Give you some background information. So back in late 90s, we took a lot of inspiration from Australia, and there were 3 EPI programs based in academic, urban hospital centers. A bunch of stakeholders. One of them is John Traynor, who is really phenomenal in terms of helping us secure funding, he decided to bring together what he called a social organization. So it wasn't just service providers who said we needed EPI. He brought in families, clients of services, a wide grassroots level where we lobbied all levels of government and all sides of the parliament. And then in 2004, 2005, the Ontario government said, okay, we see the need. This is where we expanded. At that time, it was 5 urban EPI programs to over 56. And that was with $22.5 million. And at the same time, they released a framework. So it was a little bit like a blueprint. This is how you're supposed to implement these EPI programs based on the international literature that was there. And then they said, okay, well, you do have a lot of people you have to uptrain, and you have a huge workforce to really teach this new specialist model. So every year they gave us money to get together and have a conference and have training within this conference to establish these new EPI programs. But they didn't release until 6 years later, almost 7 years later, the provincial standards that these programs needed to follow. So you can see here, you kind of did things a little bit backwards, right? So you're supposed to, roll out evaluation at the same time as you put in programs. Well, we kind of rolled out the programs, and now we've got the standards. But those standards became key because a lot of the things that my previous speakers have spoken about is exactly what happened in Ontario in terms of getting the funding. But how do you stay relevant on the political agenda 12 years out, right? And these standards ended up being one of the key areas that we sort of latched onto. And then in 2011, they said, you know what? We like you enough as a network. We're going to give you annualized dollars to be a network. So very similar to what Bob Heinzen talked about in the US, where they're creating EpiNet. This EPION, or previously known as OWG, was funded by our provincial ministry to exist as a network. And I'll talk a little bit about why that's so important. So just in terms of EPION, we are province-wide, we're actually volunteers. So, and we're service providers, persons with lived experience, and families. And we are over 56 programs. And what we do is we collaborate, we share, and we help each other train, and we improve our services. The one working group or committee that I wanted to focus on is the Standards Implementation Steering Committee. So this was actually formed by the ministry that funded the EPI programs after the release of 2011. And they wanted, their mandate of this Standards Implementation Steering Committee is to enhance program capacity to meet those standards. Let's start doing the evaluation, they're saying, right? And what was really good about this group is that it's not just EPION. Yes, we had the stakeholders, the people that's doing the frontline work, but they had on this group local and provincial health authorities, our funders, and they built in academic and research support through the Centre for Addiction and Mental Health. And so what we did, one of the first jobs that CISC did was to do 2 province-wide surveys, and I kind of want to use some of those results to highlight, I think, the importance of how we ended up staying relevant after all these years. So this is my boat out on Lake Superior, the largest freshwater lake in the world. But the provincial surveys are done by Janet Durbin and her colleague Avra Salik led. So the Ontario standards, these are the standards, they're service delivery domains, quality domains, and accountability domains. And we divided up survey 1 into the service delivery, and then survey 2 in terms of the quality. Just one slide each on each of these surveys. So I debated about providing this really busy slide, but so this slide, I'll just take you through it. What color it looks like. Okay, so the light purple top bars are the large programs, larger than 2 FTEs per program. One of the things I didn't tell you, we have 56 programs, but some of those programs has 1 FTE. How do you deliver the full basket of EPI services with 1 FTE, right? And we go from 1 FTE to 15 FTE. So we were looking at our programs and saying, well, how are you doing that service? And the little bottom burgundy bars are the small 2 or less FTE programs. So if you look at the top, there's some things that doesn't matter if you're a small or large program, you do well. Relapse prevention, appropriate use of antipsychotic medication. And then as you go down the slide or the graphs, you start to see that if you're a small program, you don't do certain things very well, right? You just don't have the resources to access to psychiatric assessment, family role and assessment, family support. And then at the very bottom, there's certain things, it doesn't matter if you're a large program or small programs, we're not doing very well or meeting our standards, which is, the example is public education. And one of the things that we have realized is that this survey suggested is if you fund a whole bunch of programs to do frontline, it's hard then to carve out certain parts of it to say, now, not only do you have to see the 20 caseload that you have, you also have to go to this mall and start doing some public education and outreach things. It's not going to happen, right? These are acute frontline people that just don't have the time to do that. So the second survey, we asked about provincial capacity. We looked at some of the standards, but then we also asked people, what do you think we need to do to improve, right? So we are now 10 years out. Let's see how we can still improve what we're doing. The one thing that I wanted to highlight was the program networks. Networks are a unique feature of the Ontario EPI standards. It was thought that EPI is a multi-component complex model, we all know that, you know, the one FTE, the network arrangement can expand the capacity and the quality and the geographic reach. And I think that sort of was the secret, I think, to our success, particularly in the rural areas. And there's different models of how we did the network. But just in terms of our survey, you can see the colors are really bad. But anyways, so the bright neon color is the small, and then the greenish turquoise are the large programs. The small programs depend on their networks to deliver the full basket of EPI services and to improve quality. But it's interesting, the large programs, more than the small, need more support, which suggests that the small programs, ironically, the 1, 2, 3 FTEs, they're well supported because they belong to a network. Okay, so more pictures of Lake Superior. Okay, so how did this work? It's interesting. Roger talked about sort of, you know, you have the problem, you have the politics, and you have the policy. Well, we really feel that there were a few things that happened at the same time that really created the stability, right? There was the release of the standards. There was already some setup to let's start doing some evaluation and system-wide planning. And then there had this strong community stakeholder, you know, Epion. I mean, we had 96 and 100% participation in those surveys, right? So whoever participates 100% in surveys, you know, this whole sector did. And so we had broad grassroots connections as well as a social organization. Then we got funding support from the province. And then we also had infrastructure support. So we think that some of the successes in Ontario was driven by the sector involvement, right? We talked about how engaged this group is. And then we are now leading the work on standards. So, you know, the province started this steering committee, but then they said, well, we're not going to be able to maintain, we can't depend on bureaucrats. So we'll just rest it in Epion. Let Epion take the lead in helping this whole sector improve and continue to improve. And of course, we're saying, great, let's do it. We're not afraid to ask the questions about fidelity. We're not afraid to ask the questions about standards, and let's try to improve. And then it's that co-creation of knowledge. Of course, nothing is perfect, right? So yes, what helps us to be stable was the annualized funding, you know, the release of standards and the institutional support. But there are always challenges, right? I alluded to it before. I wish we had fidelity and outcome data right from the start. Wouldn't it have been lovely to use that now as evidence? As, you know, 10 years out, people are starting to ask, well, is the promise of EPI being realized? We have no data, other than individual programs, perhaps at research centers that were able to say their program can. But we don't have province-wide data for that. And we need to update our standards, right? I mean, they were released in 2011, but they were created 4 years prior to that. It just took that long for the bureaucrats to release it. So we have more information now to add to it. And then to remain relevant to the policy agenda. It's always, as they said earlier, it's, you know, there's other more important programs that come along, and to maintain that this is still a problem message is always a challenge. Of course, these are my so Gresham Conrad was one of the first co-chairs of Epion. Janet Durbin, I've talked about her research, but Catherine Ford was the senior bureaucrat at the ministry that has been one of our champions. And she's now left, but she presented with us, as well as I've done a number of sort of advocacy from the inside. And that's where sort of the reach of not only politicians, but also the bureaucrats came really important. Thank you.
Thank you, Chai, and it's just what we needed, and I think it's good to have not just some good news, but some really good examples of how to network this and what resources you need. I now invite Catherine Boydell to be our discussant, and Professor Catherine Boydell comes from Sick Kids Hospital originally. We stole her from there to be Professor of Mental Health in Sydney, Australia, and because we valued her translational scientist skills and her qualitative skills, and also the connections between the arts and rigorous science, which you've been seeing in a previous session today. So, without further ado, Catherine.
Thanks very much, Alan. I'm sorry, I've been taking notes throughout, and of course, I know I've got about 5 minutes, and I want to leave some time for some discussion. So I'm just going to pull together my thoughts based on the discussions. And I guess I'm in a rather unique position as being part of the Epion group and having worked with John Traynor for a number of years, and beginning to gain an understanding of the Australian context over the last year and a half. And as a Canadian, always having looked to Australia as a leader in this field with EPIC, with the work of Oregon, with Alan and Roger's pioneering work in community-based care. So it's been sort of a lovely meshing of two worlds. And I guess one of the things I want to pick up on is, I think we've heard a lot about lessons learned this afternoon, some of the strategies around and the challenges in achieving change. And I think for me, Roger, I really take from that quote, knowing is not enough, we must apply. And of course, a lot of my work has really been focused on this knowledge to practice gap, on knowledge translation and exchange. How do we ensure that our research is communicated to the important stakeholders who need to know? And of course, I think three really important and valuable stakeholders emerged in the conversations this afternoon. Key are policy and decision makers. Second would be the press, which is interesting, the importance of the media. And third, service users and their families. And I guess one of the things I wanted to sort of address in terms of thinking about this is that we've got a huge emerging and burgeoning literature in the science of knowledge translation right now. So how do we share our research knowledge? How do we communicate with these key stakeholders? How do we network? And I think there's a really strong evidence base out there. And I just wanted to mention a couple of them specifically around communication with our policymakers, and some of the work that I've been involved in recently has been using deliberative dialogues with policy and decision makers, quite broadly conceived. And the whole notion of deliberative dialogues was started by John Lavis from McMaster University in Canada, and he's published a lot in this area in terms of how do we engage with policymakers in a way that will be effective. And in fact, I've had the opportunity to conduct deliberative dialogues in Canada and in Australia with policymakers at quite a senior level to engage them in terms of how does the policy process work, having an understanding of how the research process works, and really seeing the huge gaps in the two worlds on many levels. I mean, one of the issues that came up this afternoon was the whole notion of time, and time for policymakers and time for researchers are very different. So, of course, as we all know, what's relevant, the whole notion of a deliberative dialogue is that the issue has to be of importance. And again, thinking about communicating with policymakers, how can we make that happen? How can we engage them? And I think one of the sort of key learnings for me this afternoon was moving beyond that appeasement stage to really sort of be more vocal and fighting, and sort of thinking about what kinds of solutions can we come up to, sort of thinking about both of those paths. I think the other notion is the best spokespeople are families and consumers working with professionals. So I was hoping we could engage perhaps in a little bit of discussion about the notion, moving beyond deliberative dialogues to some of the work that I know Alan and his colleagues have been engaged in around open dialogue and the ways in which that might help us in some of these endeavors. And I think I'm going to stop there. I think we've got perhaps 5 minutes if anyone wanted to ask any questions of any of the panel members.
It doesn't have to be a question. It can be a statement. It can be a declaration. It can be a manifesto. Keep it brief. Do we have another microphone in the room? Oh, you got it. Thank you. We've driven you into submission. We were hoping to inspire. Thanks, Eric.
So I think this reminds us of the time scale of these projects and so developing services. And we are talking really about 10, 15, sometimes 20 years. And the time scale of the political system is much shorter. You build up a relationship, you develop trust, and then there's a change of government. And it makes us, I think we have to rely on, something that is more stable and something that is also, in the end of the day, we changes too. We were talking about 10-year outcome study, 20-year outcome study. One day will be gone. And it's really, I think we need to think about how to build things into a system that is more self-perpetuating. And it is not, but a lot of things are lost in a system. When the aspirations and the persons are gone, how are these retained? I saw a poster this day, New Zealand, and the title captivated me. It's about reinvigorating the early psychosis team in Auckland, after 20 years. How do you keep that spirit going? And that's something I think I would like to raise and for some ideas in the audience.
What I do is teach people how to burn out. And why burnout is important is because you have to redefine it as coming to your senses, and you have to take some time out to rethink what you are doing, either individually or collectively. But the other thing that Eric is an old friend, a good friend in this network. Your base in Hong Kong teaches us that we also have to attend to the values of the government and of the people. And there's a wonderful balance in Hong Kong that's sometimes only expressed on the streets between individualistic aspiration type values and collective values, and how we have to meet the balance between both of those. And I think in early intervention, for instance, there is a science of it. There is a head part and there is a heart part, and the heart part is also connected to traditions and to the anthropological and cultural values, not just the values of progress in the society.
I just wanted to pick up something that Catherine said at the end about the involvement. Oh, I'm Heather Hobbs. I'm also from Ontario and co-chair of EPION. Just new though. About involving people with lived experience in your lobbying efforts. And I know that the bureaucrats wanted to hear the stories, and we sent along the family members and the clients to tell their stories. And Pat mentioned that when he went to the press, when things were very dire, he took a young woman with him to tell her story. So I would support, if you are in trouble and you're in danger of losing your funding, you gather the clients and the families to tell their stories, to go to the press, to go to the government bureaucrats.
Obviously agree with what Heather said. What Eric said, one thing we didn't say was that all the other political parties in the election had completely signed up from the beginning of the campaign to restore these services. The Labor Party and the Greens and Independents. There's a very influential politician in Australia called Nick Xenophon, who is it's hard to classify him actually, but he's he's got crossbench power, you could say, and they all came on board and said this is a big mistake the government is making, and so Eric's point about you can't rely on one side of politics. You've got to get all sides of politics on side, and so if there is a change of government, you don't lose out. And we have actually achieved that over the last 10 years or so federally, because they've continued to build these reforms over 10 years. That's why it was so bizarre that this, and as I say, I think the bureaucrats were responsible, not the politicians, for this, although the politicians went along with it. And the bureaucrats are, in some cases, a lost cause, because they're so detached, and you can't influence them as much. You know, I don't think in that way that Heather described. They're not as sensitive to the public. You know, and they, as Roger said, they turn over a lot. But if you get a bad one, it's very destructive, and that's what happened to us.
Can I just say one thing too? Behind all this is also the neoconservative view that there should be small government and the smallest safety nets possible. And so what they're doing with these primary health networks, and the state governments are doing with the local health districts, is passing out the funding and then making them make the rationing decisions when there's not enough money to go around. So that it doesn't come back to the people in government. It's not their fault, it's those people over there. So in fact what happened was that I know that of the other programs that were Commonwealth money going through the PHNs, they sliced some money off almost all of them. So the PHNs were screaming that they were losing money to actually run their organisations as well.
You get the last say.
Hi, I'm Charmin Robertson. I'm also from Ontario. I'm one of the committee chairs of Epion. I'm wondering if other people are experiencing this shaving of funding that happens every funding cycle. So if you speak to the funders, the middle bureaucrats, they'll say, we're not cutting funding. So you'll get the same amount for 6, 10, 12, 18 years. And in that time, you're not keeping up with cost of living, and you've got unionized positions, and it affects our ability to produce the whole basket of services. So how does one deal with that on a more micro level?
That's right. Steve, I'm just wondering if you wanted to comment on the UK situation, since just for a minute.
Well, we don't see any change of government anytime soon, I don't think. So, but I suppose that.
If you Brexit, you've got to fix it. How long are they going to last?
Well, we'll see. I can't call that quite, but I suppose the biggest change that's coming, that people are struggling with at the moment, and that is probably an opportunity, is that the region the money is being put towards, I suppose, that where there is money, the sustainability and transformation plans. So they've carved up the UK into 44. It's looking a bit like what were the strategic health authorities, but some of them are very mismatched. So, for example, they don't it's just yet another overlapping way of dividing up the country. So the ideas behind it are that that services are going to be integrating and saving money again, but the problem is that it's not well enough defined how that's going to happen. So already different regions within the sustainability and transformation patches are beginning to kind of posture and compete. But one of the promising themes is that it's very much partnered with 5 years forward, which is the kind of last mental health plan that's underpinning it, is that there's the prevention agenda is a big part of it. So we've had a very successful collaboration, which was quite surprising really, called the Crisis Care Concordat, where a lot of the acute care services joined together and actually did cooperate and make a good deal of progress. And I think the hope is that a prevention concordat of some kind will be similarly successful within these STPs.
Hope reigns eternal. So thank you, everybody. Thanks for coming. Thanks for staying and sticking with it. And here's hope to all our services. Till next time. Thank you.